Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Cases from the Community. As today we talk about the management of gastroesophageal and hepatobiliary cancers, and we're trying a format we've never done before in this webinar, so it's kind of like a phase 1 CME experiment. Our faculty today by video, I met with these two docs. They were both and part of a GI symposium satellite we did in San Francisco this past January. Dr. Lipika Goyal from Stanford University School of Medicine in Palo Alto. She was on the faculty for our program on HCC and biliary tract cancers. And Dr. Zev Weinberg from the UCLA School of Medicine and the Johnson Comprehensive Cancer Center in Los Angeles. Zev was on the faculty of our program on gastroesophageal cancers. And I followed up with them after the GI symposium and I interviewed each for an hour, no slides, just talking with the whole idea of kind of a program you might listen to. And tonight, actually, we're going to play excerpts of that and have it commented on. This is kind of the reverse of what we've been doing the last 3 years of taking videos from docs in practice and presenting to investigators. Tonight, we're going to do the opposite. So we have three general medical oncologists who are going to be commenting on these very short videos, sound bites. Dr. Eric Lee from Fountain Valley, California. Dr. Neil Morgenstein from the Atlantic Health System in Summit, New Jersey. And Dr. Swati Vishwanathan from the United Hospital Center in Bridgeport, West Virginia. As always, if you have any questions or cases you'd like to, or comments about what we're talking about today, just type them into the chat room and join the conversation. We put out a very brief 1-minute survey for you to take before this meeting. We get started here, and then we'll give the same thing at the end and see how it changed and learn a little bit about you, and you'll probably get a lot more out of the meeting.
Chemotherapy and the dangle or the allure of immunotherapy is always out there, and I know the trials aren't there, but I haven't done it, but boy, do I want to sometimes.
And Swati, actually in the program, Dr. Weinberg talks about some of the trials that are looking at FLOT or integrating IOs into the FLOT patients, whether it's FLOT or something else. Again, any thoughts about this kind of scenario in your practice and some of the issues that come up as you try to deal with these patients, Swati?
Absolutely. The first issue when patient presents to us is first making sure we're getting appropriate staging, EGD, US, PET scan. And sometimes I will say diagnostic laparoscopy also becomes important to rule out peritoneal mets. And sometimes that's a challenge for me to get our surgeon to do the diagnostic lab, because sometimes I've seen patients, we push the FLOT regimen through, and unfortunately during surgery, they're found to have peritoneal mets. So that's one issue. The second issue, in terms of treatment, I rely on my gastroenterologist to tell me if it's predominantly gastric tumor versus a G-junction tumor, esophageal tumor, because that kind of changes my approach, right? Because if it's predominantly gastric, I'm going to do FLOT. Whereas if it's like above the gastric level, then I'm thinking more of the cross regimen, chemoradiation, because I would prefer to do chemoradiation because we have the adjuvant nivo data only after chemoradiation and not after FLOT. So I think talking to your gastroenterologist, making sure you're fully understanding the location, the anatomy, and then choosing the regimen accordingly. That's very important, because I personally right now for gastric, I'm not using immunotherapy. I'm waiting for the data. I would do FLOT, peri-op the 4 cycles, and then take them to surgery and complete the 4 cycles post FLOT after surgery. And in terms of G-junction tumor, I am sticking to the Checkmate 577 regimen, which does not differentiate based on histology or the PD-L1 level. It's strictly if the patient has an R0 resection and has residual disease, I am trying to do the year of nivolumab. But what I have seen, sometimes it is difficult to give that whole 1 year. So I would be curious to know if, say, I do 6 months, or if I don't finish the 1 year, would I still reap the benefits?
So Eric, I'm going to show you another clip and get your reaction. We're going to start to pick up the pace here a little bit, because one of the things that we've tried to do over the years, is kind of quote go beyond the guidelines. A lot of times, if you go to guidelines or you go to up to date, you see a whole bunch of options. What we try to get down to is like, what do you actually do in your practice outside a clinical trial? We know it's different for every patient, but like, how do you make an individualized decision? And I think the complexity of that really comes out in this next topic, which is first line therapy of metastatic disease.